All right, everyone, welcome. Today, we're going to tackle one of the most fundamental processes in all of medicine, inflammation. Now, a great way to think about it is like the body's own fire department. It rushes to the scene of an injury to control the damage. But for this to work, it has to be perfectly balanced. Too little and the fire rages on. Too much and the fire department starts wrecking the whole neighborhood.
So here's our game plan. We'll kick things off with the basics, the why of inflammation. Then we'll get into the 5 classic signs you'll actually see in your patients. After that, we'll zoom out and see how a local problem can become a whole body issue. We'll then dive into the lab tests we use to track it, and we'll wrap it all up with a nice, clean clinical summary.
Okay, let's dive right in. To really get a handle on inflammation, we have to start with its whole purpose. Why does this process even exist in the first place?
Okay, so here's the absolute key takeaway right from the start. At its core, inflammation is a good thing. It's a protective response. Its job is to get rid of whatever is causing the trouble, whether that's a bacteria, a virus, or just damaged tissue, and then to kickstart the healing process. But, and this is a huge but, it's a total double-edged sword. When that response goes haywire, like in septic shock, or it gets chronic and confused, like in autoimmune diseases, the cure can actually become worse than the disease.
Okay, so now let's talk about what you actually see at the bedside. For literally centuries, we've recognized inflammation through 5 classic or cardinal signs. These are your bread and butter, your first clues that something inflammatory is going on.
And here they are. Rubor, which is just redness. Calor, or warmth. Tumor, which means swelling, not a cancer in this context. Dolor, which is pain. And finally, functiolesa, or the loss of function. You absolutely have to know these cold. They are the foundation of your clinical diagnosis.
So, the first 2 signs, redness and warmth, are really 2 sides of the same coin. They're both caused by vasodilation. Basically, the little blood vessels, the arterioles, just relax and open up wider. This lets a rush of warm red blood flood into the area, which is why the skin gets red and feels warm to the touch. And this whole process is kicked off by chemical signals like histamine and prostaglandins.
All right, so what about the swelling? Well, at the same time the arteries are opening up, the walls of the tiniest veins, the venules, become leaky. It's kind of like a garden hose suddenly getting a bunch of tiny holes in it. This lets a protein-heavy fluid, we call that exudate, leak out of the bloodstream and into the surrounding tissue. All that extra fluid piling up is what you see and feel as swelling or tumor.
Now, you might think the pain is just from all that swelling pushing on things, right? Well, that's part of it, but it's not the whole story. You have these chemical messengers, especially bradykinin and prostaglandin E2, that directly irritate the local nerve endings, making them way more sensitive. And that last one, loss of function, that's really just the logical result of everything else. If your ankle is swollen, hot, and throbbing with pain, you're not exactly going to go for a run, are you?
Okay, so we've covered the local scene. But what happens when the fire gets too big for one fire truck? Sometimes, those local chemical signals spill into the bloodstream and trigger a full-body systemic response.
Fever is such a fascinating process, and this is how it works, step by step. It all starts with something called a pyrogen, literally a fire starter, like a piece of a bacterial cell wall. This tells your immune cells, your macrophages, to release messengers called cytokines, especially IL-1 and TNF. These cytokines travel all the way up to your brain's thermostat, the hypothalamus. There, they trigger the production of prostaglandin E2, and it's that PGE2 that tells the hypothalamus, hey, let's turn up the heat, causing a fever.
So, while the brain is cranking up the thermostat, another cytokine, interleukin-6, sends a powerful signal to the liver. And the liver basically switches gears. It becomes a factory, massively changing what proteins it's making. It starts churning out a whole set of special proteins we call acute phase reactants.
And that leads us perfectly into our next topic. How do we actually measure this stuff in the clinic? We can't easily measure those cytokines, but we can absolutely measure the downstream effects. Those acute phase reactants the liver is pumping out. This is the hard evidence of inflammation we look for in a blood test.
It's pretty straightforward, really. We split these proteins into 2 main groups. The positive ones are the proteins the liver makes more of during inflammation, so their levels go up. The negative ones are the proteins the liver makes less of, so their levels go down.
And this table is awesome because it shows you the body's strategy. C-reactive protein, or CRP, is a big one. It acts as an opsonin. Think of it like putting a bright eat me sign on a bacterium for your immune cells. Fibrinogen helps with clotting. Then you've got this cool strategy to hide iron from bacteria. Ferritin locks it up, and hepcidin stops you from absorbing more. And this last one, procalcitonin, is super useful for us clinicians because it typically only spikes in bacterial infections, not so much with viruses.
So you might be asking, why on earth would the body make less of something? It all comes down to smart resource management. By making less albumin, for instance, the liver frees up a ton of amino acids that it can then use to build those more urgently needed positive reactants like CRP. It's a very clever trade-off.
Now for a classic test, the ESR. This one's an indirect measure. So think of it this way. Normally, your red blood cells have a negative charge, so they repel each other, kind of like magnets. But during inflammation, all that extra fibrinogen in the blood coats the red cells, neutralizing their charge. Now they can stick together, forming these heavy stacks, like a roll of coins. And in a test tube, these heavy stacks just fall to the bottom way faster. So a high ESR tells us that something is making the red cells sticky, and that something is often inflammation.
Now, I cannot stress this enough. The ESR is incredibly nonspecific. You have to be careful with it. As you can see here, all sorts of things can raise it. Anemia, pregnancy, kidney disease, you name it. And other things can falsely lower it, like sickle cell disease, where the weirdly shaped cells can't stack up properly. That's why we almost never rely on an ESR by itself. We always look at it along with a more specific marker, like the CRP.
All right, we've gone through the local signs, the body-wide reaction, and the lab tests. Now let's pull all those threads together and see the big picture.
This table right here, this is your high-yield cheat sheet. It connects what you see or measure directly to the underlying process. You see redness and warmth, you think vasodilation. You feel swelling, that's increased vascular permeability. The patient has a fever, that's PGE2 in the hypothalamus. The lab calls with a high ESR, fibrinogen is coating those red blood cells. It's all about making those connections.
So if there's one thing you walk away with today, let it be this. Every single sign, every symptom, every lab value in inflammation tells a story. From the red patch on a patient's skin to the CRP number on a lab report, each piece of data is a clue that points back to a specific process happening at the molecular level. Your job as a future clinician is to learn how to read that story.
All right, I'm going to leave you with a little clinical puzzle to chew on, based on everything we've just talked about. If you have a patient with a high CRP, but a totally normal procalcitonin, what does that suggest to you about the cause of their inflammation? Think about it, and we'll dive into more clinical scenarios next.